So I will just focus on what are the newer therapeutic pharmacological armamentarium which is included, and especially the importance of that in the management of hypertension. For a length of time, in JNC1, the Joint National Committee, JNC1, JNC2, we were harping, or even the step care program, we were harping on beta blocker and diuretic as step one. And after that, the next step and the next step started coming in. But for the first time in 2002, this live trial came to was published, and then you will not believe that how long the applaud lasted when this trial was presented in ESC, and then there was a very long applaud, standing ovation, that for the first time they saw that something in comparison to the beta blocker was more effective, and that was losartan. The death, myocardial and the stroke, DMS, the CV death, myocardial infarction and stroke, there was 13% risk reduction in comparison to the atenolol. And so also on the left-hand side, you will see the left ventricular hypertrophy was also reduced. So that was 2002. And this is even further amplified if you see the stroke, the sub-study, the secondary endpoint. The stroke was reduced not 13% but 25%. And when this came to light, that stroke is different in atenolol versus losartan in live study, then Lindholm came out with this meta-analysis, which included 7 trials. And then he showed that there is almost, you can see on the extreme right side in the forest plot graph, the relative risk, 29% higher risk of stroke when atenolol is compared with any other drug, which may be beta blocker, calcium blocker, ARB, ACE inhibitor, so on and so forth. The ELSA, the INVEST, the LIFE study, so all of them showed increase in the stroke rate as a result of using atenolol, which was the standard of care before 2002. For almost 40 years, in 1962, Sir James Black discovered beta blocker, and after that till 2002, till life trial came, then beta blockers had the absolute emperor's position in the armamentarium, whether it is ischemic heart disease, hypertension, arrhythmias, so on and so forth. But this 2002, the things changed. 2005, this meta-analysis came, and then further, not 7 trials, but this is 47 randomized controlled trial meta-analysis, and that again showed that, as you can see here, thiazide versus any other drug, beta blocker versus any other drug, then CCB versus any other drug. So only the CCB were the great winners, as you can see here, with number of trials being 25, the lowest column, and showing this 10% relative risk reduction in the stroke rate. So, and that was attributed to something different property of this calcium blocker, and that is the central aortic blood pressure reduction. Especially in ASCOT BPLA trial, it was seen that although the blood pressure, the brachial blood pressure was same in the older treatment, that is atenolol and beta blocker, versus the at that time they called newer treatment, the CCB and perindopril RAS blockade. So the brachial blood pressure was the same reduction, but central aortic blood pressure was different. And then the atenolol did not reduce the central aortic blood pressure, but the CCB and RAS blockade reduced it, and that led to this benefit in terms of heart and stroke rate, so on and so forth. And that gets reflected into how effect on the heart in left ventricular hypertrophy regression also. So CCB and ERBs are again the great winners, and that was seen even in accomplished trial. The ACE with diuretic and CCB with ACE, the RAS blockade with CCB was again a winner in terms of producing a better reduction in the event rate. And that's why in the various guidelines you will see that RAS blockade and CCB, they are in the top zone. And RAS blockade, of course, you know that it has become a very important therapeutic target for our treatment, because angiotensin 2 is considered as a murder molecule. That whether it is at the cellular level, the intracellular, at the receptor level, the vascular level, endothelium, organ. So at all these levels, angiotensin 2 has various effects which are negated by RAS blockade. But RAS blockade is achieved with ACE inhibitor and ARBs again. But then if you compare this different drug armamentarium which we have for blood pressure, like diuretic, beta blocker, alpha blocker, CCB, ACE inhibitor and ARB. ARBs have the least amount of side effects, so they have the best adherence to the treatment. As you can see here in this particular slide, at the end of 1 year, the number of people adhering to the RAS blockade, and even the new onset diabetes, which necessarily was harping quite often in the last, I mean, in the first decade of this millennium, that quarter million, more than that, people in the America, the new onset diabetes is attributed to the hypertensive therapies. That is because of this beta blocker and diuretic. But then the new onset diabetes is again least with ARB. So this ARBs is a very important therapeutic armamentarium in hypertension management. And the first drug to get approved was losartan, and which we saw in the live trial, which was very, very successful in comparison to atenolol, with 13% the primary endpoint reduction, 25% stroke reduction. And after that, one after the other, different the angiotensin receptor blockers started coming: valsartan, candesartan, irbesartan, telmisartan, olmesartan, and the eighth sartan, that is azilsartan, that is the newest, the latest approved drug about 10-11 years ago. It has very specific benefit. It has some structural carboxyl, but because of some carboxyl ring or something, it gets very firmly adhered to the angiotensin 2 receptor and takes long time, so prolonged duration of action. And it has very potent action, very firm interaction with the receptor. So you can see, even after the washout in the animal studies or from the tissue studies, after the washout of the organ, after that also the azilsartan is firmly seen binding to the angiotensin 1 receptor. And its effect also, as you can see here, comparing with telmisartan, olmesartan, azilsartan, then that is the best with azilsartan. And especially with olmesartan, the comparison is very pertinent, because olmesartan came as the best, the most powerful ARB with double-digit reduction in the blood pressure. So even with that, comparing with olmesartan, as you can see here, olmesartan medoxamil versus azilsartan medoxamil, there is better reduction. And 20 milligram, 40 milligram, and even 80 milligram is the dose. So that even is seen in multiple trials, including multi-center placebo active control trials, as you can see here, with valsartan, olmesartan, so on and so forth. More importantly, in our Asian population, we are very fond of salt, adding salt to everything. And this salt sensitivity, as you can see on the right hand side, that salt sensitivity, the high salt diet increases, is shown in the after the administration, is shown to increase the blood pressure. And after administration of azilsartan, as you can see here, in the upper part, the solid black azilsartan, there is an acute dip in the blood pressure, but which is not there with candesartan. So the salt sensitivity is differentially benefited by this azilsartan. So these are the different particular peculiarities about azilsartan, which make, especially even in our Asian population, very important. So this is another study with double-blind this thing. Of course, this renal study will be taken care by Dr. Dedia, so I will not harp on it. So these are the different benefits of azilsartan, which not only it binds to angiotensin 2 receptor very firmly for prolonged duration, but it has got additional the mass receptor benefit, then this carboxyl ring, oxidizole ring, so on and so forth. And then that's why this American Heart Association has emphasized that in resistant hypertension, 24-hour ABPM studies have demonstrated that azilsartan provides average additional 4 to 8 millimeters of mercury more than all other ARBs, as we saw in the previous studies, which included olmesartan and candesartan and telmisartan as well. And second important drug that we are discussing in today's, that will be the last 5 to 7 minutes, is the calcium blockers, which came way back in 1967 because resistance is increased. Vascular resistance is increased because of the constriction of the peripheral vessels, and peripheral vessels are constricting because the smooth muscle cells in the vascular media are powerfully contracting. And if you want to reduce the contraction of the smooth muscles in the vessel, we have to block the actin myosin bondage in the vascular smooth muscle cells, and then that can be achieved by blocking the calcium entry to the smooth muscle, and that is achieved by this calcium blocker. So that was a very simple postulation at that time, and it did work. That the first generation in 1963, first generation calcium channel blocker, the verapamil, then diltiazem, and then the first generation, this dihydropyridine, first generation was nifedipine, then philodipine, then isradipine, amlodipine being the third generation, and the latest is, of course, this today's topic of discussion. The newest addition is, of course, cilnidipine. Cilnidipine, again, as we talked about azilcertan, why this is different? Because it doesn't block the standard calcium pathway, which we are more familiar with dihydropyridine calcium blockers like nifedipine, philodipine, isradipine, and amlodipine, and so on and so forth. But it also blocks the N channel, and then that's why it blocks the adrenergic effects. And adrenergic effects on the heart, kidney, vasculature, they, all of you know that they are very, very pertinent. And that's why, especially when you give this calcium blockers, normally we expect vasodilatation, fall in blood pressure, and there is a reflex because of baroreceptors reflex, the reflex sympathoadrenal activation. And as you can see here, that with amlodipine, amlodipine, the third generation amlodipine and fourth generation cilnidipine, the reduction in the blood pressure is seen with all the four drugs. But there is a very gentle, robust reduction, but very gentle gradual reduction with cilnidipine. And then there is no heart rate reduction, and plasma norepinephrine also is not increased, which is very acutely increased with nifedipine, the immediate release nifedipine. And then that's why in 1993 there was Furberg's paper said that nifedipine 60 to 80 milligram, the immediate release produces increase in the heart attack rate because of this reflex sympathoadrenal activation, which increases heart rate, BP, plaque, the platelet aggregability, and then acute event, whether either stroke or myocardial infarction. So these are the different benefits of the fourth generation CCB calcium blocker, that is cilnidipine. That dual channel blockade, no reflex sympathoadrenal activation, the heart rate doesn't increase because of sympathetic activation is not there, and increased lipophilicity and prolonged so on and so forth. Especially in our Asian population, younger age group with hypertension, they have more increased sympathetic activity. As you can see here, the renal adrenergic norepinephrine spillover in 20 to 30 age group is much more in comparison to the 40 to 60 and 60 to 80 age group. And then it cannot be sympathetic activity is not judged easily with heart rate, because as you can see here, the three bar diagrams, the mean arterial pressure, the black and the shaded and then empty, as it is increasing, the sympathetic nerve activity, which is either detected in the previous slide with renal spillover, or this simply by doing the muscle sympathetic nerve activity. So that shows that in our young population, that is responsible for blood pressure, and then reducing this sympathetic activity helps. Another benefit with cilnidipine is the blood pressure variability that gets beneficially affected, because that also plays a great role in this cardiovascular event rate. As you can see here, the Kaplan-Meier curves with BP variability and the CV event-free survival, they are separating as the variability in the blood pressure is more versus less. And then you can see here the different CCBs, the cilnidipine, there is good reduction in the BP variability in the extreme left corner, you can see here, as opposed to that with other CCBs, it is not there. So also this central aortic blood pressure, the pulse wave velocity, as you can see here, the left ventricular mass index. So all these are better benefited with cilnidipine. So when you are treating blood pressure, it's not just the number which we have to treat. You have to have the 24-hour BP control with prolonged action, as we saw with azilcertan. We should reduce the BP variability, as we saw with cilnidipine. The morning BP surge with we should reduce, and the night dipping. This is just one case of 72-year male diabetic and then CKD and then this who already has edema. So you will think about adding diuretic hydrochlorothiazide, but that again will increase this plasma norepinephrine and then RAS activation, and then you need something else. And then looking at the previous slides, you would agree with me that changing the CCB to cilnidipine will be helpful, because that produces the better 24-hour action and then less edema. 24-hour action is the best seen in this particular study, which was again done by Cairo et al. In 2013 in Achieve 1 with more than 2,000 people, a Japanese study again. And then that you can see here with just morning dose, 77% people were taking single morning dose, and as you can see here, ambulatory BP monitoring, and then this that is benefited in Achieve 1 study with cilnidipine better in comparison to this from baseline to 12-week study. And then the heart rate also reduces. But then very importantly, you can see that people get worried if the person has a heart rate of 60 and 64, will it become less? But you can see here that people who have less heart rate, less than 70, there is not much reduction in the heart rate. People who have heart rate more than 85, as on the right hand side, you can see that there is a reduction in the heart rate of 9.7. So the benefit is proportionate to the baseline BP and the baseline heart rate. And then you can get a good 24-hour control, which can be seen in this 6-week studies and 12-week studies. And this is another study from India, 2012, from Haryana. And then that also showed that at that 6 weeks, this the blood pressure management, the heart rate, everything, and ambulatory BP monitoring showed that benefit was better with cilnidipine. Now, last few slides, I think 3 minutes I would go for that last 3 slides. That very important part is difficult to manage blood pressure, because way back you will see at 1970s when many people were not taking treatment. 69% people are in blue that were untreated. But then even after taking the treatment, 90% of the people who took the treatment, they used to fail to achieve the blood pressure goal. But even in this current millennium, you will see that although there is 0%, people are aware, they are taking treatment, but again, 50% people are not achieved. And there are various reasons with lifestyle, obesity, metabolic syndrome, kidney disease, so on and so forth. And as you can see here, that untreated people, treated but uncontrolled. So finally, very small number of people are controlled, and that leads to various target organ damage, including brain, heart, eyes, heart, kidneys, so on and so forth. And with these different components, we have to take care of not, I said, only the blood pressure with medication, but we have to look at the comorbidities. There may be this abnormal diet, abnormal salt intake, the patient adherence to the drug, concomitant diabetes, the race, so on and so forth, and then replace the existing drug with more potent drug, the drug which has got more 24-hour action. And as you can see here, the preferred drug, which is in December 2022, just 2 months back, the International Journal has this publication that in ARBs, the preferred are telmisartan and azilsartan. In CCBs, preferred are cilnidipine and amlodipine. And then, of course, the third step, as we saw in the previous ACD, the ARBs, CCBs, and Ds diuretic is the third this thing. And last 3-4 slides are about this nifedipine, because in some of the countries I heard where I'm talking to today, this cilnidipine may not be available, and still nifedipine is very commonly used. So if you are using nifedipine, we should use a sustained release or this very different formulation of nifedipine. This what is called as gastrointestinal therapeutic system, in which there is a laser hole, and very gradually the drug is released. And as you can see here, the nifedipine immediate release is producing acute rise in the plasma, this area under, not area, the peak plasma level, as opposed to that these JITs are producing very less gradual rise, and then sustained effect for longer time with not having any acute rise in plasma so nifedipine level. So there is no acute fall in blood pressure, no acute reduction in the blood pressure, no reflex sympathoadrenal activation, and no increase in the myocardial infarction stroke, which we saw in that Furberg's report in 1993. And there is a good BP reduction if you compare with those when the nifedipine came at that time. It was compared with diuretic. It was compared with the most potent drug for hypertensive surge, that is hydralazine, intravenous or acute hydralazine. So with all those things, it was the potent medicine. It was seen that produces good reduction. So this long-acting nifedipine with this Oros technology or this JITS technology, it has slow action, long duration, gradual reduction, good bioavailability, one-study dosing, and that doesn't produce reflex sympathoadrenal activation and no edema. And then that was seen in this INSIGHT study, which came in 2002, that nifedipine JITS results not only in those plasma level and reduction, but it adequate plasma level, but it reduces even this event rate, that INSIGHT study 2002 that presented by by Rosenthal et al. That this sudden death rate, the death due to unknown causes, etc., all of them are reduced. So this is a absolute last slide, just to summarize what we spoke in the previous 45 minutes, that hypertension is a disease which was once considered essential to perfuse the body and compensatory to have the adequate perfusion. But then subsequently 1945 onwards, after FDR's death, then the things changed. Then it has become very important. Number one killer, the silent killer, as it is called today. There are different tools with which we can treat it, and then different tools with which we can diagnose it. And when we are diagnosing, we should keep the proper definition and then proper attention to not only the office BP, but then the daytime home BP, nocturnal BP, early morning BP. Especially in younger people, we have different pathophysiology, including this adrenergic surge and hyperadrenergic state, etc. So where different drugs work differently. Maybe again the dual calcium channel blocker will have an edge, and then different pleiotropic effects which we saw with azilsartan and then CCB, they will be beneficial. And last but not the least, in some of those countries where the cilnidipine is still not available, nifedipine, this extended release formulation should be the drug of choice again when you are using CCB as step 1, as it is given in the current guidelines. Thank you very much indeed for a very patient hearing.